Health for Life. This is the first ever medical show on television that deals with prevalent health problems and concerns, and they do so in an easy to listen to question and answer format. To find out what we're discussing today and to introduce us to the visiting specialists, here is the producer and the host of Health for Life, Dr. Surendra Prasad.
Good afternoon. I am Dr. Surendra Prasad, and welcome to another episode of Health for Life. Health for Life is a program designed to inform the public about common medical issues and conditions. Today, we will be discussing an issue of great concern to all of us, and primarily to couples who are planning a family. That issue is infertility. My guest physician today is Dr. Madhu Singh. Dr. Madhu is the medical director of the Balwant Singh Hospital and is the driving force behind the development of the infertility program at the Balwant Singh Hospital. Dr. Madhu, thanks for joining us and welcome to the program.
Thank you, Dr. Prasad.
Let me congratulate you and the Balwant Singh Hospital on the birth of the first IVF baby. So let's go right into the talk. What is infertility?
Infertility is defined depending on the age of the patient. Earlier, it was just defined as there was a common definition of a couple that has been trying to conceive for 1 year and has failed. Unprotected intercourse for 1 year, and they have not been able to conceive. But the definition is changing now because of the importance of age of the female partner. So the definition of infertility now depends on the age of the female partner, and anybody who's more than 35 years old, it's only 6 months of trying. Okay. So if after 6 months of trying, a woman who's more than 35 years old should definitely seek attention. And a woman who's less than 35 years old, the 1 year definition still holds.
Okay.
So that's how we define it.
Okay. Now, we are reading in the papers, the article reflected the magnitude of this issue. And from the questions we've been getting, it clearly is a significant problem. What would you say is the magnitude of this problem worldwide and in Guyana?
We don't have any clear-cut statistics. I'm hoping that I will be able to develop some statistics of my own. But definitely from my practice, I would say between 15 to 20% of all patients we see are suffering from infertility. It's a significant percentage of patients. And the American statistics are also saying the same thing. Between 15 to 25% of all couples will face this problem. In Guyana, this problem has been minimized to an extent because most women tended to have very large families. And so people don't realize that there is a very real issue with infertility. But as women are putting off childbearing and women are being educated more and are becoming more career-oriented, this problem is going to become larger.
Now, traditionally in Guyana, we've grown up with a culture of where whenever there's an infertility problem, we're always saying it's the female or it's the woman's fault. But we all know that there is a role, infertility can have issues in the male. So is infertility always a problem with the woman?
It's not always the woman's problem. 30% of infertile couples the problem will be with the female partner. 30% will be with the male partner, and 30% will be a combination of both or unexplained infertility. So you can see that the woman and the man contribute equally to infertility.
I'm sure many of our guests would be surprised to hear that. Yeah. So what you're saying is 30% primarily in the males, 30% females.
Primarily in the females, and 30% is a combination or unexplained and what is called unexplained infertility.
So how do you deal with that? I'm sure when some of these couples have come in, there's a blame that has already been placed.
It's almost always, there's some amount of blame and some amount of, the female partners, in-laws would have been blaming her, and then there's always this, and we really need to get away from this blame game story in infertility, and therefore we always want to investigate a couple and not just the one partner, either the female or the male. And invariably, I would say 99% of the time, the female will present alone and will want to be investigated. We can start the investigations for the female partner alone, but we want to see the male partner very early in the whole process.
What do you find is the greatest challenge with convincing the male partner to come?
Men, especially in Guyana, are not very forthcoming in infertility investigations. There'll be all sorts of excuses. There'll be issues where they'll say, I already have a family, I was married before and I have 5 children elsewhere. But it's never good medicine to just investigate one of the partners, and it's always good, even though the male may turn out to be quite normal and healthy, but we need to have baseline values on both partners.
So tell us, in the workup of this, is that a couple has come into your office and you're initiating the evaluation. Tell us about what is being done or what you will be doing to investigate the male infertility.
Male infertility, we would ask the male partner to come to us after 3 to 5 days of abstinence. And after taking a history from him of sexual function, we shouldn't be dealing with, we are doing a semen analysis, but actually the main problem is erectile dysfunction or premature ejaculation. And once we've ruled those things out by just taking a history, then we proceed with the semen analysis.
Okay.
And the semen analysis parameters have been changing over the years. Over the years, the human population, this human species, is becoming more and more infertile.
Yeah.
And so WHO is bringing down what is a normal sperm count. Okay. It used to be more than 40 million about 15 years ago. They brought it down to 20 million. Now, recently, just 2 years ago, they brought it down to 15 million is considered a normal sperm count. Of course, just the numbers of sperms is not the only thing that we look at. We also look at how many normal sperms are there, how many are actively moving. Those are all important parameters to look at in a sperm count.
I want you to go back to that count, because I'm sure you have found this, that when you say 20 million or 15 million, most persons don't understand. You're not talking about in the entire sperm.
No, it's per ml.
It's per ml.
Per ml. Right. It has come down from 40 million per ml to 20 million per ml, and it's now at 15 million per ml. Okay. So you can see that they are bringing down the criteria as we are becoming less fertile. And so because now it's at 15 million per ml, but a lot of people are not aware that the sperm count, a normal sperm count, is actually 15 million per ml. So a lot of men would be told by their physicians, I guess, that, oh no, you have a very low sperm count. And it's actually quite okay. If it's more than 15 million, the man is fine. You can't really tell him that you have a low sperm count. So because the international standards are now at 15 million. And of course, in any sperm sample, there will be a certain percentage of, even in a very normal sample, a man who has been able to be able to have a child quite normally, there will be a certain percentage of abnormal sperms. But this percentage, you should have at least more than 5% normal sperms. Okay. 5% should look normal.
Right. So you're looking not only at the total amount, but the functional aspect.
That's right. The motility. Sperms have to move into the female genital tract, as we will show you in some videos later. They have to be able to move. They have to be able to navigate into the female genital tract and find their way to the egg. Unlike the egg, which just strolls down very slowly into the tube.
In your clinic, what do you find is the largest obstacle? What is it that you have to do to get the men to understand why it's important to have this analysis?
You have to be able to tell the female partner that you can't go beyond a certain point unless you have the male parameters. So, and then it's up to them mostly. Some of them will say, "Doctor, can you speak to my husband or my partner?" And I would do it quite readily and explain to them that, the woman alone can't make a baby. There has to be half the contribution is yours. And most of them will come around. Some will say, "Not today, doctor. Can I come back?" There'll be a significant percentage that will say that. "I'm not so comfortable, doctor. Can I just come back?" There'll be a little hesitation initially, but then they come around.
Now, let's go now to the causes of infertility in women.
Okay. In women, the most common cause of infertility is, contrary to popular belief, it's really not blocked tubes. The most common cause of infertility in women is anovulation, which means that the ovaries are not releasing an egg as they should. They are producing, a lot of them will be producing the eggs, but they will not mature and be released on time as they should, which is 14 days before a woman's period. So I would say causes of infertility in women, I would put the first 3 causes as anovulation. Anovulation, anovulation, anovulation. After that, we can deal with blocked fallopian tubes, which is usually secondary to an infection, which is called pelvic inflammatory disease. The third thing I would say is fibroids, which are some special types of fibroids, which are located in some special areas just below the lining of the womb, or physically at the entrance of the tubes, and these may cause infertility. And there may be other physical problems with the uterus, such as anomalies, where the uterus doesn't develop normally. So these women, these are the causes of infertility in women.
Now, as we discuss the causes, are there factors that can affect a woman that may increase her risk of infertility?
Just as I said, anovulation, 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 the factor that I would like to stress on most with women that predisposes them to being infertile is the first thing is age, the second thing is age, and the third is also age. So the age of the female partner is extremely important, and the one message that I would like to send to your viewers today is that women must not put off having their first baby beyond the age of 35. And a lot of women may think, but doc, 35, I haven't finished anything, I'm still studying and I'm trying to, get somewhere in my career. Well, all the advice that I have for you ladies out there is that if you ever think you're going to want a baby, and when the biological clock starts ticking, well, don't wait for it to start ticking at 40, because then you'll have to start using donor oocytes, which is what we'll talk about a little later. The next factor that is going to predispose women to being infertile is being overweight, and this will come under lifestyle modifications for a lot of us. Okay. When you're overweight, you are likely to have polycystic ovaries, which is related to metabolic syndrome and all of that. And I keep telling my patients that the hormone imbalance is not causing the weight. The weight is causing the hormone imbalance. You have to put the egg before the chicken. And then, of course, there are sexually transmitted infections that women may pick up, which are going to lead to blocked fallopian tubes. So that, I would say, is the third factor, if you want to list it like that.
So to reiterate what you've said, the key is have that first child
before 35.
Before the age of 35.
Before 35, because after 35, your fertility is going to start declining.
So let's discuss this age, because like you said, times have changed, women are more involved in advancing their education. So what is the importance of age as it relates to the woman's ability?
When a woman ages, what happens is women don't make new eggs. They are born with the oocytes that they have, and they get these oocytes when they're inside their mother's wombs. Okay. And these oocytes start to mature. A lot of them actually die even before the girl is born, the female child is born. And then she'll have some left over, which will start maturing at puberty. They don't mature from the time of birth up to puberty. Some will continue to die, but they'll not start maturing to give us an egg. So they will start to mature at puberty, and generally what happens is one egg should mature in every cycle, but a lot more will die. So there'll be growth of large number of follicles, but only one is going to reach maturity and give us a viable oocyte. So as a woman gets older, you have to now realize that a woman who's 35 years old, all her eggs are 35 years old. So you're now trying to make a newborn baby with a 35-year-old egg. And as age progresses, that is what happens. This is the age of the oocytes, but also women's ovaries become more resistant to releasing these eggs. They don't release eggs as readily as a younger woman's ovaries. They will not mature, they will not be released. And miscarriages are more frequent in older women. Also, partly attributed to the same thing, to ovarian aging, to oocyte aging. Okay. These are all factors that contribute with the age.